Hello, my name is Mitch Ellis. I'm a registered nurse. I graduated from Ashland University in 2018, and then I worked in trauma ICU and then a cardiothoracic ICU for the three following years. And then now I'm in nurse anesthesia school. But today I will be talking to you guys about healthcare for intervention specialists. So even if teachers are not directly responsible for performing these procedures, they should have current knowledge of best practices for meeting specialized healthcare needs. The literature shows that teachers of students with severe disabilities should know about the care of seizures, med administration, tube feeding, tracheostomy care, ileostomy and colostomy care, suctioning, diabetes, asthma, and catheterization. The primary role of a special education teacher is to give quality and meaningful education to their students. But like many other professions, your role is always expanding. And aside from teaching, you're also an advocate, resource, and a healthcare provider when the child is at school. Collaboration. So, American Federation of Teachers has a strong view that nursing services must be available and work underneath the school nurse. As delegation of care increases by the school nurse to LPNs and aides, the intervention specialist must also collaborate to ensure that the impact of the student's medical needs do not impact their education. If you know how to fix the problem and get the task done quickly and safely without having to call in the school nurse and it's within your scope, you can continue to educate and the child can continue to learn. Collaboration between the educator and the school nurse is crucial for this scenario to be successful. Universal precautions. So we're just going to start with precautions in general. These are precautions taken universally in all potential exposure situations. So whether or not a person is involved, the person involved actually has an infection or not, you should still be using these precautions. So what are universal precautions? Proper hand washing, PPE, which is personal protective equipment, gloves, mask, eye protection, and gowns, cleaning off the area that has body fluids on them, and then dispose of sharps in a puncture-resistant, leak-proof container. So we're going to talk about feeding tubes. I don't know if anyone has seen feeding tubes yet, but we'll kind of go in depth on everything here, and you guys can kind of start to picture it in your head. It's a method used to ensure that the child gets adequate nutrition. It is a liquid nutrition that is infused through a flexible tube that goes directly into the child, either through the nose or through a port directly into the belly. There are different types of tubes, as well as tube feeding mixtures that have different ratios of calories, macronutrients, fibers, and protein depending on the child's disease process and needs. So here are some types of feeding tubes. We have the nasogastric feeding tube, which is an NG tube that you'll hear. You have nasojejunal feeding tube. You have gastrostomy tubes, and then usually they're going to be called PEG tubes, percutaneous endoscopic gastrostomy. And then you'll have jejunostomy tubes, which go a little lower into the intestines. So here, let's see if my mouse works. I don't know if you guys can see that. So here on the far left, you have, starting at the far left nose, you'll see nasogastric tube. And that'll go all the way from the nose down and sit in the stomach. Next on the right, you have esophagostomy tube, which goes directly into the esophagus in the neck area. These are a little bit more rare to see. Next, in the right, like mid-right, you'll see gastrostomy tube. See, I can't even say it. And those go directly from the skin directly into the stomach. Next, over here on the left, you see nasoduodenal or nasojejunal. So these are going to go from the nose, and it just depends on the depth. So they'll either go from the nose and sit in the duodenum, which is right after the stomach, or they will go past the duodenum into the jejunum. And then you have a jejunostomy tube as well, which is similar to a gastrostomy tube, but just a little lower in the jejunum. In the middle picture, figure 1, you see a cross-section of a PEG tube. So remember, a PEG tube is going from the skin directly into the stomach. These are pretty common. So you have an adapter, a like tubing clamp that allows it to be clamped so nothing comes back, like backflowing, as well as you can then instill it in. You have an external bumper that is kind of used to keep it in place. And then you have layers of skin, fat, and muscle. And then the catheter goes all the way down into the stomach, where there's an internal bumper that stops it from migrating back up. And then you have the mushroom catheter tip, which is just kind of like the end of the catheter that has little holes that allow the nutrition or medications to go into the stomach. Then over here on the right, it's practically the same thing as you can see. So you see skin, you see the bumper, the internal bumper, and then you just see the ports at the top here that you have different ports that you can use. And then you can obviously just go deeper and turn it, not turn it, but you can have a jejunal feeding tube, which is just going lower. So next we're going to talk about medication and tube feed administration. So there's different ways to administer tube feeds that we're going to get into. You can have oral syrups for medications. You can have pills that are going to be crushed up and instilled and mixed with tap water to instill. You're going to have different feeding routes, like not routes, but different ways to feed with gravity versus with a syringe, which may be called bolus feeding. Using gravity feeding sometimes takes a little longer, which I'll show you guys. And then let's see here. Aside from that, you'll have some feeding pumps from time to time as well. And those will kind of be per hour, and it'll instill a certain amount of mLs per hour. So now we're going to demo. Let's see here. Yeah, before we go there, we're going to demo. So this is my water that I can't mix with my drinking water. So let me set this to the side. So what you're going to have is usually like some sort of basin. Let me see if I can bring this down here. So you're going to have like a little basin of water, something like that, or that you'll see. You might not do this, but a syringe, and usually it's going to be a larger syringe. So this is 60 cc's. And then some other examples here. This is our example of a like PEG tube port. So right here is where the syringe gets placed into. So it'll be like this, boom. And you want to make sure that's tight, and you want to make sure that this other port is closed. You can see that. So nice and tight, not going anywhere. And then now, this right here is our clamp that we talked about. So if it's closed, it's going to look like this. And now we're going to open it. And now we're ready to instill things through it. So usually you want to have it closed when there's nothing connected to it. And there's a little cap to this guy right here. So what we're going to do is, just to show you guys, I'm going to draw up some water. I feel like I'm in a YouTube cooking course. Alright, so then, as we can see here, I'm going to open this. Nothing comes out yet because it's dependent on me pressing this down. So now I'm going to press. Ta-da! Whoa. So this would be going directly into the stomach. Okay? Now, let me clamp this off. Disconnect. I'm going to get water probably everywhere. So now, let's say they have medications, okay, that we need to do, to administer, or something along those lines. So right here, a lot of kids are going to have GI and like constipation issues. So for example, this is like Miralax. This is fiber, okay? So that's a laxative, and then this is like a fiber supplement. You'll see these used pretty frequently, given with nutrition too. So aside from medications, they might be on a whole bunch of other medications that the nurse will crush up and place inside of here. This is a syrup example. So this is Senna, that's another laxative. So these are all graciously donated from my previous hospital. So right here, let's pour a little bit of the syrup in here. Ooh, that looks iced tea. And then some fiber. And this would be all into like a basin. There you go, some fiber. And then some laxative. And this happens also in the ICU. A lot of nurses are doing this for their patients as well. So I'm very well versed with these medications here, because everyone needs to poop. So aside from our other medications that they might be on, or daily medications, pain meds, something along those lines, you're going to mix them, or the nurse will mix them all in here, or the aide, or whoever, and mix. You want to make sure that there's not a whole bunch of clumps, and if there are, you just want to add more water and kind of dilute it a bit. Then you're going to draw it up, for example. See, I got a clump there. There we go. So draw it up. Going to hook this guy into here. So here's our medications. This guy into here. Unclamp. I can see this guy's trying to come out. Unclamp. And administer our medication into the belly. And so this is our this is a push method. So you can also do a gravity method, which would just entail taking out the plunger. And I would, this is my drinking water, gravity method, it's hooked up into, let's say this was hooked up into here. Now I'm really going to make a mess. So hooked up into here, into there, into there. You guys can see all that. And then I'm just going to pour. This is totally going to, there we go. And it really depends on the gravity, but also this is what it would look like. So I'm holding it here, and it's going in. Okay, so that's gravity. And that's how you do that. So I had to pause and clean up my area a little bit, but now we're back to it. So so that would be how those medications are instilled through a PEG tube, for example. And then the also mixing of medications. So it's the same process with tube feed. So if the child or student needed a certain amount of milliliters of feed through a bolus, you would just draw the syringe up with that, and you'd administer that either nice and slow, nothing like too crazy fast, or through gravity. So moving on, we're going to talk about complications of tube feeding. So we want to ensure that the site doesn't look any different. Red, swelling, and pain indicates inflammation and possibly infection. You want to notify the school nurse if you see any differences like this. Vomiting and aspiration due to bad formula, delayed gastric emptying, or a blockage like an ileus could be the root cause. Diarrhea, either by giving the tube feed too fast, intolerance to the formula, which is pretty common, bad formula, low fiber formula, or a hypertonic formula. You want to notify the school nurse or the family if changes occur in the child's tolerance of the feeding and their output. So here's an example. On the top right, you'll see this is what it should look like. Sometimes they'll have a bumper and you won't really see the entrance point as well, but this is what it should look like. And then the picture right below that, this would be a little bit of a cause for concern. So a little bit of erythema or redness around the site. Sometimes you could see some pus. If you see the site turning black at all or brown and discolored, you always want to tell someone, because that's a cause for concern. So next we're going to talk about urinary catheters. So a urinary catheter is just a flexible tube for draining urine from the bladder because the child or student is not able to do so on their own. Usually this is due to some sort of paralysis or a decreased ability to contract muscles of the bladder. And there's two different types of catheterization that you're most likely going to see. An indwelling catheter, also known as a Foley catheter, which stays in the patient for a period of time and then gets replaced, or a straight catheter, which is used on a schedule, and the patient gets catheterized, they drain the urine, and then they take the catheter out. And we'll demonstrate that here. So this would be an example of a Foley catheter. So as you can see on the bottom left here, it's a male and a female, and then you have the catheter going up through the urethra into the bladder, and then a balloon with saline is inflated in the bladder, and it stops it from coming back down the urinary tract. So it allows for the bladder to drain without having to take the catheter out, and the catheter stays in place and is hooked up to a bag. So here we're going to do a demo again, so let's see how much problems I can get into. So this is just a little syringe of saline. This is what the catheter looks like. So this is the end of the catheter that's sitting in the bladder. So this is the bladder right here, and it's sitting in here. This right here, this port right here with the little orange bit to it, you'll see it says the diameter, 16 French, and it'll say the amount of mLs or milliliters you want to instill into the balloon. The balloon is right here. So to show you what it looks like, and I'll show you the bag after, this is 10 mLs of a syringe. You're going to hook this up, not you, but someone will. You're going to hook this up to here. This thing's old, so hopefully, there we go. It doesn't leak on me. And then right here you can see these little holes here. That is where the urine drains into, and then it comes down and drains out. So right now I'm going to fill the balloon. And as you can see, the balloon is filling. And so this sits inside the bladder. And then I'm going to disconnect this without making a mess. This is an older catheter, so it's not super compliant. Well, it's stuck on there for good. That's okay. So this is the bladder, and it's sitting in there. And then it allows it to not come out the bladder. So next, I'm going to deflate this guy. To take it out, they deflate it, and now it would be okay to come out. There we go. So why not? It's working for me now. There we go. There we go. Perfect. So now it's inflated. The syringe is off because you're not going to leave the syringe on there. And then what would happen is it would be hooked up to a bag. So this is a bag where the urine collects. This right here. There should be a seal on this. This should not be. There's usually a seal like right here. So this doesn't really come off too frequently, but depending on the chronic use, the seal might not be there. And then it would drain from the bladder, which would be here, all the way down, and into the bag. Cool, cool, cool. I'm going to set this down. Let's move on. So, urinary catheter care. So, the insertion is a sterile process. The nurse or LPN or whoever should be using sterile gloves. It's prone to infections, obviously. Ensure the catheter tubing is clean. If you notice that the aides, LPN, or nurse is not being sterile, you may need to intervene and tell someone or have that discussion with them. If the indwelling or Foley catheter is being used, always make sure that the bag is below the level of the child's bladder to ensure draining is occurring. So number one, it's for draining, but number two, if the bag is below or if the bag is above the bladder, so let's say the bladder's here, and this bag, to move it over to the other side of the wheelchair, something along those lines, the bag gets lifted up. This urine, any urine in here could back drain, and there could be bacteria, and then you're risking a UTI. So, especially in immunocompromised patients, a UTI can be pretty detrimental. So, it's important to minimize raising it above the level of the bladder. If urinary output stops or decreases, it's important to make note of that, because there could be an obstruction or the child could be dehydrated. And then minimum urinary output is usually for most adults or adult-sized people 30 mLs per hour. It kind of varies a little bit depending on the size of the person. So colostomies and ileostomies, they allow for the removal of stool. Both have the same purpose. It's just to remove stool from the GI tract. And the location is where the difference in name comes from. So a colostomy tend to be from removing solid waste from the large colon, and the waste is more solid because water reabsorption occurs in the large colon. So you're going to see solid waste. In an ileostomy, you're going to see watery waste because it's in the small intestines before it gets to the large colon. And this is before water reabsorption back into the body. So here's an example. This little fella or girl has a colostomy. And so you can see there's a little bit of redness there. That's totally normal. So you want it to be red, moist, and painless. It is the inside of the intestine. So that's what you're seeing, and that's why it looks all pink. And there shouldn't really be blood or anything like that. It just should be pink. And then, as you can see on that picture on the right, the stool collects in the bag, and then usually at the bottom of the bag there's either a clip or it's a couple folds that is adhered to like Velcro. So colostomies and ileostomies, the stoma site should be red, moist, and not sunken in. Around the stoma should be free of rashes, and the bag should fit well around the stoma so that leakage and skin breakdown does not occur. There should be no pain. Stomas have no nerve endings. The pouch should be emptied into the toilet or into a container when half of the bag is full of gas or stool. Depending on the pouch, usually it's changed every few days, like the actual adhering part, and the bag itself. But it's emptied, obviously, as frequently as needed. And if it's emptied not often enough or changed not often enough, it could lead to skin breakdown. So pro tip, change at least 2 hours after meals so the GI system is less active, and the more hands, the better. Let's see here. Change if any leakage around the stoma site occurs, or if there's any itching, skin breakdown, or burning. If the child is fussy for no apparent reason, this could be a reason for that. Especially in nonverbal children, you kind of want to keep an eye out for their lines, their ports, their drains, and see what's going on. Is that the reason they're so fussy? Tracheostomies. So tracheostomies are an airway adjunct for when a child is unable to breathe on their own or needs assistance breathing, as well as if they have weak coughs, and we need to help suction out any mucus or gunk that's in their lungs. So reasons for having a trach: blockage of the upper airway, paralyzed vocal cords may block the airway, inability to clear mucus from the lungs and airway, decreased ability to cough or clear mucus, increases the risk for pneumonias. If a chronic ventilator is used, it will go through the tracheostomy, and then most frequently you're going to see portable ventilators if you're going to see any, and they'll be usually hooked up to the back of a wheelchair or something along those lines. The nose and mouth are bypassed in a trach, which is usually responsible for filtering, warming, and humidifying the air. So a lot of times, if they are vent dependent, the air is moistened, the air is humidified a little bit. Some devices allow the child to speak through the trach, which are called speaking valves, which we'll see in the next picture here, but not always. So sometimes they'll be having issues phonating because they um, the valve is open the whole time, and so the reason that we make noises is because of different levels of closure of the vocal cords. So that's impaired in a tracheostomy. So tracheostomy care, ensure that it is kept clean and watch for signs of infection. A mucus plug may occur if the child has problems breathing. This is usually the cause. And then suctioning is a sterile procedure as well, so sterile gloves are used. Here, the picture right in the middle is an example of suctioning. It's a little tube that's hooked up to a suction device, and someone will insert it and suction out the trach. At the top, you'll see so airway is just your trachea, and then the trach tube is the tracheostomy, which will have sometimes an inner cannula to it, so it's like an inner tube within a tube, and that inner cannula can be changed out pretty frequently if needed, and as well as you can just clean out the inner cannula or the trachea itself, or the trach tube itself, with that suction device. And so on the right side of that is where you'll see the suction device being used and taking out the mucus. So tracheostomies, don't be scared of them. So as a new grad nurse, I was terrified of trachs, but at this point, those were usually new trachs, and they're bloody, and they're kind of a little unstable and not secure. They're sutured at the time. These ones are a lot more secure. The parents know how to manage them. A lot of times some of the kids will know what to do with them. So here on the left, you'll see this little girl has a speaking valve, and so she should be able to phonate through that a little bit. It might be a little different sounding, but you can still make out what they're saying. And then in the middle picture, it looks like she's getting a little bit of oxygen or humidification through that trach. And then over here on the right, this boy has possibly like cerebral palsy and has issues ventilating. So he's in a wheelchair, but as you can see, there's a tube coming from the trach down, and that's going to the ventilator. And so most likely it's helping him breathe a little bit and giving him breaths or helping him with some pressure to breathe. And really quick, as you can see, so I told you guys that in the ICUs and stuff that they'll be sutured, but at this point they're going to have trach ties, which are just like soft bands that go around the neck and kind of Velcro on both sides of the trach to keep it in place. Sometimes they'll be changed, but most of the time, like at this point, they're not going to get super dirty. So seizures and epilepsy. So seizures occur when there's an abnormal excessive electrical discharge from the brain that results in an altered motor, sensory, and behavioral or emotional function, with or without changing consciousness. So epilepsy is a condition in which recurrent unprovoked seizures occur. The prevalence rate of epilepsy amongst people with intellectual disabilities has been reported at least 20 times higher than in the general population. Epilepsy is often caused by the same brain damage or impaired development that has caused the intellectual disability. Here's a little diagram of seizures. You won't be tested on this because I don't know if you're going to be tested at all on this. Purely informational. So right here, generalized is the more common. You're going to see tonic-clonic and absence seizures, which absence seizures are more so just kind of staring off, and it lasts for a few seconds. It's almost like they zoned out and then they like come back to. Tonic-clonic is what you really think about when you see a seizure. They tense up and then they like start the jerky movements. And then you have the myoclonic, tonic, and then clonic and atonic seizures as well. So seizures, what do you do? So first and foremost, you want to protect the child or the student. You want to cushion their head and move items away from them. You don't want them to be smacking up against a desk or anything like that. You don't want to put anything in their mouths. Do not put your fingers in their mouths because they don't have control and they will bite down and possibly hurt yourself. So You also don't want to hold them down like you see in Grey's Anatomy, because you want them to and the muscles to contract and not be stopping that contraction, which could damage the muscles and the joints. Um, and then you want to turn them on their side if possible, because they could vomit, and you don't want them to aspirate. So you don't want the vomit going down into their airway and their lungs. So turning them on their side, letting them vomit to the side is your best bet. Obviously, call for help, and then you want to time the seizure. If in all that you're helping the child, you're turning them, you're trying not to freak out yourself, and then you want to take a quick look at the clock, see how long the seizure lasts, and you want to kind of keep an eye on the seizure. Is it absent? Probably not. If they're on the ground, is it clonic tonic? So just kind of keep an eye on that too, and that way you can best describe it to the nurse, you can describe it to the parents and EMS. So when to call EMS, it's obviously going to depend on your school's protocol, the nurse's protocol, but you want to uh, keep this in mind. If the student hasn't had a history of seizures in the past, and this is a new onset seizure, that's a pretty red flag. If the child is having difficulty breathing, if the seizure lasts longer than 5 minutes, if another seizure quickly starts after the first one ends, and if the child is hurt from the seizure, so if they fell and hit their head, if they're bleeding, if they're hurt anywhere, or if you're not even sure but they might have hit their head, that's also a good call to call EMS. So next we're going to talk about diabetes, type 1 versus type 2. So type 1 is usually diagnosed at a younger age. This is because the pancreas does not produce insulin. Therefore, the child or student requires exogenous insulin, which is just a fancy word for insulin from a vial. And they require insulin injections or a pump of insulin to be administering that into their bloodstream throughout the day. So type 2 is a little different. It's related to obesity and insulin resistance, but it also has a genetic component as well. The cells can't use insulin in the body, and they become resistant to it. And this allows the glucose to stay in the bloodstream and not leave the blood and go into the cells. And then this is becoming more and more prominent as we see childhood obesity rates increasing. So signs of hypo and hyperglycemia. Hypoglycemia is just low blood sugar. Hyperglycemia is high blood sugar. So hypo, they're kind of going to look a little drunk, if you can think about that. So they're going to be sleepy. They're going to be sometimes a little sweaty. Pallor, which is just pale. They're going to kind of lose coordination, stumble around. That could be kind of a sign. They could be a little irritable and fussy, and they could be hungry as well. And then hyperglycemia, they're going to have dry mouth, increased thirst, blurred vision, weakness, headache, and frequent urination. So they're going to be peeing a lot because they have a lot of sugar in their blood, and their body's just like, I need to get this sugar out. So it pees the sugar out. Their breath may be a little bit fruity smelling. So these are all things to keep in mind, and if possible, get a blood sugar on them using a device or talking to the nurse. So care for students with diabetes. So blood sugar tests are pretty routine. You're going to have them checked before they eat, after meals, sometimes just on a schedule as well. They're going to be receiving medications, sometimes oral medications, as well as insulin administration. And insulin goes subcutaneously, so it goes into like the fat. So usually the most common sites are like belly, like kind of like back fat, and then tricep, like back of the arm fat. And so it's a small little needle injected there with the dose of insulin, and then it gets absorbed through the fat into the blood, and then is able to decrease the blood sugar. And then insulin pumps, as you can see right here, this picture, that's an insulin pump. It has insulin in it, and it measures as well as administers insulin. So it measures blood glucose as well as administers the right amount of insulin for it. But it's still important, even if they have this, to keep an eye out for signs of hyperglycemia, because sometimes these machines have have errors. So allergies. These are the 8 most common allergies that make up 90% of allergic reactions in children. Milk, eggs, peanuts, soy, wheat, tree nuts, fish, and shellfish. And I said cashews, but cashews. Anaphylaxis. So usually it occurs within a few minutes of exposure, but sometimes it could take multiple exposures to build the reaction up. So let's say I eat a peanut for the first time, I'm okay, but then the second time I eat a peanut, I start to have a reaction. That's because my body kind of saw that, made the allergic reaction possible by sending out like the different mediators and antibodies and stuff, and then it, like, the second time it really spikes it up. So then signs and symptoms of a reaction is a skin reaction, like flushed skin, hives, hypotension, constricted airways due to swollen throat or tongue, wheezing, trouble breathing, tachycardia, and then dizziness or fainting. So that's usually because of the low blood pressure, because you have mass dilation of your blood vessels. EpiPen administration. So you want to remove the injector from the carrier tube, remove the blue safety shield from the top, push the injector firmly into the outer space of the thigh, and hold firmly for 3 seconds and remove the injector. So blue goes to the sky. So you want to put the blue up, and then the orange side goes down, because otherwise you're going to inject it straight into your hand, and the child or student will not be getting the epi, you will. So make sure blue to sky. Let's see. Know where the EpiPen is at all times, and depending on policy, usually you have to call the parents, you have to notify EMS, because once the epinephrine wears off, the reaction may come right back because the reaction is lasting longer than the epinephrine does. So that's why you'll see sometimes a child will have a dual jet, which is 2 EpiPens together into like a little case. That's just in case after the first one, the reaction comes back before they get medical attention. It needs the child needs another injection. Asthma. So what causes asthma? Usually it's common triggers like exercise, allergens, dust, pets, mold, smoke, grass, and chemical odors, as well as cold air in the winter. Upper respiratory tract infections may also trigger asthma. Therefore, it is recommended to get flu shots every year if you have a history of asthma. What is it? So an asthma attack is an it's an immune response to a trigger. It causes inflammation and the narrowing of the bronchial airway, which is not treated. If not treated, can cause death. So here we have some inhalers and medications for asthma. So the short-acting ones are going to be here on the left. That's your like albuterol, and if you're exercising or the child's exercising and they get short of breath, they take a couple puffs of those. On the far right is your preventing ones. So these are most likely going to be steroids, and they'll use it every day or on a schedule. If they have extreme asthma, they might take medications like a pill of a steroid instead, which is stronger. And then you'll have other controllers like long-acting, and then combinations of short-acting and long-acting, or steroids and long-acting. So those are kind of the different inhalers that you could see. So 7 goals for creating an asthma-friendly school. Establish a process to identify students with asthma. Allow students to have their inhalers near them at all times. Establish a school-wide process for handling worsening asthma. Identify and reduce common asthma triggers in the school. Encourage students with asthma to participate in school activities. You don't want them just sitting out because they have asthma. And then provide asthma education for the staff, students, and parents. Always good if the peers know that someone has asthma and where their inhaler is, so they can run and grab it for them, um, as well as with an EpiPen as well for anaphylaxis. And then collaborate with families, healthcare providers, and the school. So our leaving message, so collaboration with other teachers, school nurses, assistive personnel, administration is needed to ensure that everyone has adequate training and resources available to provide care to these students. It's important to know the medical background of your students so that you can keep them healthy and safe and focus on giving them meaningful education while not letting their comorbidities or disease processes affect their education. Just a reminder, you're never alone. There's always available resources nearby. If you're concerned about something that you see in a student, reach out to the school nurse, administration, or parents. If something doesn't look right, the best bet is to go with your gut and speak up. So you'd be surprised at what you catch by just something not looking right, and you identify that. So that's all I really have. I think. Thanks for listening. You can reach me in my email if you have any questions or want additional resources on different topics, or you see something in the field and you want to learn more about it that you can't really find anything online about. Just reach out, and I can do my best to answer some questions or find the resources. Here's some references that I used, and that is all. Thank you guys for listening. Don't hesitate to reach out, and have a great day.